Well, good morning, everyone. It's great to be here. And firstly, you'll note I'm not a clinician. It's very hard. I follow a very distinguished psychiatrist, and I'm going to be followed by a psychologist, and I'm certainly none of those things. So if you've got any tough questions for me, I think I might have to either ask the audience, go 50-50, or phone a friend. Anyway, look, it's a pleasure to be here. It's lovely to see you. And I think I might change what I'm about to say on the basis of a couple of the questions that have just been asked. So Lisa asked a question about schools and whether it's possible to change the curriculum and how to connect into schools with interventions for young people. When Sally spoke before, she talked a little bit about the lowdown, which you can see at thelowdown.org.nz. That's an online tool which exists for young people. It's run as part of the National Depression Initiative. We're currently doing some work on there to better integrate into schools, but you have to do it through intermediaries, in our experience. So we're doing some great work at the moment with, of all people, the School Trustees Association and the school counsellors. And whilst it's a digital tool, one of the things we're working on at the moment is a physical tool. And I don't want to give too much away, but something that counsellors can use to physically hand over to young people to encourage them to come back into the tool and work that way. And you know, one of the points that I think Sally was making as she was winding up was talking about that move from web to mobile, and also that connectedness with and through social media. We're very much at the forefront of that. And when I talk in a moment about the journal and the National Depression Initiative, these are depression.org.nz, and then the journal, which is a self-management tool that runs off that. They're fronted by Sir John Kirwan. 50% of the visitors now to depression.org.nz are accessing via mobile. Well, that's a vast change from where we were, and it's a constant run to catch up. So anyway, yep, I'm Chief Executive of the Health Promotion Agency. It's a Crown entity established in 2012. That means we've got a board that's appointed by Cabinet. It means I'm fully bilingual. I spend half my time in Wellington and half my time in Auckland. It also in structure, it means we're the same as Pharmac or ACC or the NZTA. We're an arm's length entity from the government, but we give effect to government policy. The exception to that is in alcohol. And I noticed you very kindly gave Sally a bottle of wine. I thank you for your kind contribution, because we get 5 cents on that bottle of wine, because our alcohol work is levy funded, and that means we're required to give autonomous advice around alcohol to industry and to the government as well. So we cover a vast array of health topics. At any one time, we will be the Crown's agent on public health initiatives in 20 to 30 different areas. So it could well be we're doing something around immunisation or HPV vaccination. We could be doing something around skin cancer prevention, sun safety, any one of 100 different conditions. But big areas of work for us are around alcohol, around tobacco, because the government's committed to this 2025 smoke-free goal, which means less than 5% prevalence, and of course mental health. Now, I was asked to talk today in the context of mental health because I knew I was following Sally, but in a wider sense, a lot of the work we do is stuff that's of great interest, I know, to Atlantis, because we're talking about tools and techniques to encourage people to self-manage. So, I mean, that's where I'll go to. Is it fun? Yes. Is it interesting? Yes. Is it enormously rewarding? Yes, it is. So, John Kirwan, I was in a cafe in Kohimarama with John Kirwan, and we were talking about depression and the performance of the Auckland Blues. And they're not entirely unrelated either, I can tell you. And you looked around this cafe and you saw people who looked like they hadn't got a care in the world. You know, they're European sports cars outside, and it's, you know, a beautiful Auckland morning. And the waitress came over and was standing by us, and John was talking, and she sort of hovered by us with the order pad. And when he stopped speaking, she said, "Excuse me," she said, "a customer asked me to give you this." And on her order pad was a note that said, "JK, you saved my life." And that happens a lot, you know, that happens to him an awful lot. The National Depression Initiative has been around for 10 years. And during that time, it's had more than 4 million visits. 1 million of those are in the last 12 months. So it's an incredibly powerful tool which continues to change people's lives. And there's a lot of analysis that's done about this, and I'm not going to, I'm not capable of giving the references that Sally gave and talk about the analysis that's been done over periods of years. But what I will tell you is that more than 90% of users who have completed the journal, which is the self-management tool that exists, have reported a significant improvement in their mental health and well-being at the conclusion of this. And also that analysis has been done that's also looked at the cost saving in terms of having an early intervention that's a digital intervention. And they've looked at and come up with a 7-to-1 return on investment. So the savings to the health system in terms of this being handled online rather than a full-on clinical intervention. Safe to say you're not comparing completely apples and apples. There are obviously different strengths and different ways of working. But the saving to the government over that period has been $31 million. And that's $31 million that's then back into the health system. So that's really where we're at with that. We've done a lot of work over the last year to refresh it, to make it work. As Sally said, it's very hard, it's complicated doing this stuff. You think it's simple to change the architecture, to optimize it, to work on mobiles, to work on different devices, to interface. It's part, I think Sally also mentioned talking about being part of a connected health system. One of the big changes that's occurred for us over the last 14 months was the retendering of the National Telehealth Service. So now Home Care Medical, which is a joint venture of ProCare and Pegasus, have taken over the 0800 lines. So you dial an 0800 number on the back of this. Also, we've set up a complete social media arm. So you can interface now with Home Care Medical and get therapy via, for example, Facebook private messaging, or in any other way that you choose to do. And it's an extension of that kind of any door being the right door. So there's a much better connectedness across here. And when Sally said that people are coming to Sparks from the lowdown, that's the extension of that as well. These are not competitive programs that are seeking to do different things. They're part of an integrated and joined up system, I think, with an acceptance that's what's right for my 14-year-old son. Maybe quite different to what's right for my 16-year-old daughter. And that's, that's the reality of, I think, the world in which we're working in as we collectively seek to deliver a health strategy that is designed to meet people's needs in an efficient, connected way, closer to home. That's some of the tools that you can work through in terms of the journal. You can see positivity, lifestyle, problem solving, links through to how to get more information. So there's a constant escalation pathway. And as Sally has said, the same applies here. There are clinical panels that sit over all of this. So it works within a secure and evaluated and peer-reviewed framework, and has done for 10 years. If I've got time, I'll just talk about a couple of other behaviour change pieces of work that we're involved in. Alcohol, interesting area. That's stills from the No More Beersies, Say Yeah Nah campaign. We work in 4 or 5 different areas in alcohol. Some areas involve, for example, help-seeking behaviour. People who have a problem, and we obviously are engaged in that work. We do specific work around drinking and pregnancy at the moment. We do work with the licensed trade to minimise harm. So one of the interesting tools that's been developed there is actually an intoxication recognition tool that allows both the police on the street outside, the bouncer on the door, and the bar person serving the drink to agree what intoxication looks like, which is a very useful and very simple tool. This stuff is actually, No More Beersies was around moderation for people who were in the drinking moment. And Does it work? Well, we see all sorts of metrics that help us understand that it does work, but when the phrase "no more beersies for you" enters the national language or is picked as one of the phrases of the year or is being used by comedians or thrown across the Houses of Parliament as an insult, we feel that if you're changing the national language, you're in a way to contributing towards culture change. And so that's an interesting piece of work for us. These are the Cartoa twins. This is about rheumatic fever, an entirely preventable condition. I just like to show this up because as a consequence of this work within a connected system, this is not the work just of us, this is within the work of a very connected system, there was a 45% reduction in hospitalisation rates. What I liked in terms of behaviour change was a consequence of the work we're doing. You can see 88% of a target population took direct action, which was a case of either getting a throat swabbed or, depending on their geography, making contact with an 0800 number or talking to a medical professional. So that's work that I'm, obviously proud of. We do a lot of different topics at a lot of different times. Youth tobacco is a tough area for us. This is an interesting piece of work. I only put this up because I hated it, and it wasn't my idea. And my ideas tanked with young people, which is just what Sally was saying. So the strategic challenge in this case is smoking prevalence obviously continues to fall. There's a government target that says 5% by 2025. Certain population groups, Maori Pacific women, the rate is still very high, over 45%. And so there are specific issues which are dedicated in that particular area, but one of the blips we were seeing was a rise in, wrong way round, a slower reduction in smoking pickup rates of people aged 17 to early 20s. So in other words, you were starting to see 17, 18, 21, 22-year-olds starting to smoke when you wouldn't be wanting to see them to start to smoke. And what we were finding when we did more research around this was a lot of it was what I would have called in my generation social smoking. It was having a drink, you smoke on Friday night, or you smoke on Saturday. And actually it was quite incongruent with all the other things you were doing in your life, like maybe going to the gym, the next morning, or playing sport, or wanting to do other things. So this was a really interesting piece of work. I had some great ideas on what would work, and none of them worked. All of them were turkeys and were terrible. We tested lots of different ways of working, and if you'd told me that we'd end up with a man in a 7-foot rubber cigarette suit, I would not have thought that's where we've had it. But anyway, this is stuff that we've done that's quite targeted. It's been very interesting because it's had spillover. Not only has it worked in dissuading people from starting to smoke, it's also prompted calls to the quit line as well, which has been quite interesting. So it's had some sort of unintended consequences, as we've seen. Look, 85% awareness, 91% understanding. Even that doesn't surprise me. It's not that hard to get your head around a 7-foot man in a cigarette suit. 91% relevance and 70% wanting to see more. So that's something that we've been really quite proud of and been quite pleased with the way that's gone. It's certainly a tricky audience to reach because, one, they're cynical, 2, they're digitally connected, 3, they don't consider themselves smokers. I'm not a smoker. If you ask the question, are you a smoker? In most cases, they say no. I just had some cigarettes last night. I'm not a smoker. So very hard. And also, many of the other things, many of the rituals around it, they may not necessarily buy cigarettes. They may smoke other people's cigarettes. So it's really quite an interesting and tricky area for us, but very, very rewarding and really, really quite challenging. Look, that's it from me. Happy to give my best shot at answering any of your very tricky and technical questions.
Thanks, Clive. That was a really interesting talk, and I found the return on investment piece was particularly interesting. That you can not only deliver a better health outcome, but also save health spend through something like depression and or the Depression Initiative?
Well, I think that's interesting. I mean, we're a Crown entity that was set up in 2012. So we do the work that was done by ALAC. I should put the bottle of wine down as I say that. We do the... Thank you very much. Much appreciated. We do the work that was done by ALAC and the Health Sponsorship Council and pick up a whole load of other things as well. But there is very much that social investment model.
Yeah.
You know, the reality is that $1 spent at our end of the continuum can save hundreds of thousands later on. Our challenges are around engaging. We're not big, and engaging fully and fully cooperatively with all elements across all of the areas where we're working. So, I mean, you know, a number of people in the audience today from district health boards. You know, having that connectedness with district health boards is obviously critical to us, and it's a constant challenge for us to ensure that we're relevant, we're cutting edge, we're clinically reviewed, and we're plainly operating in a framework which means that we're open and transparent and subject to public scrutiny. So that's where we're at. But happy anyway to take any questions.
I'm quite interested in the interface between the research of health promotion and the evidence that sits there in terms of what works in the public sphere against the co-design elements you have, perhaps with young people and working with agencies to bring advertising campaigns to life. So could you give us a little bit of insight on how that process works?
Yes, it's tricky, and it's tricky when you overlay it with time as well. So as Sally mentioned, for something like the lowdown, there was an extensive co-design process where young people told us what they liked and what they didn't like. And the challenge is sometimes that what you think they'd like isn't what they actually would like. And you need to have robust and rigorous testing that sits around that and remain true and faithful to the way that's needed to be executed. So the tobacco one is a good example. What we did was we ran through GETS, the tender service, an open approach for a number of advertising agencies to submit their ideas based on all the evidence which we'd gathered. So we'd done literature reviews, we have our own research department, we pulled in everything from everyone, and we gave them all a stack like this of the evidence. We made focus groups of young people available to them, and we made them, through the procurement process, cooperate. So I said, I'm only going to pay you $1,000. You can put as much work in as you like to this, but you're going to get $1,000 each. And we're going to own everything you produce. And we may require you to work with your rival. We may take a bit of someone's idea or a bit of someone else. So the procurement process actually gets to be quite tricky in that place, because you really want to work with a private sector partner, get the very best out of it, but it's public funds. And it needs to be a robust and vigorous way of doing it. So there were some ideas I loved, there were some ideas I hated, and I was completely wrong. And what we came up with was something that, in fact, I'll tell you, I mean, one of the ideas I really liked was a notion of a hidden camera in a dairy, and someone coming in and saying, can I get 25 Marlboro or whatever brand of cigarettes they are? You have to blank the brand out, you know? And the dairy owner says, would you like regular or social? We said, what's the difference? Well, are you a regular smoker or a social smoker? What's the difference? Oh, these ones only give you social cancer. Now, I like that idea because I'm a sort of verbal person. But one, what do we know from the young people? Well, one, we know they don't buy the cigarettes. They smoke other people's. Two, they don't use the language of social. So that misfired completely. Also, you then overlay different ethnicities, and you find there are different groups that work in different ways, and visual humour. So I went back to the man in the rubber cigarette suit. You know, you see him playing a saxophone trying to woo a woman. You know, one of the things that came through that research around tobacco was the thing that unified all those young people was the nature of a relationship. What they cared about was a relationship, and they cared about self-control. Universally, didn't matter where they were. So whether the relationship was a loving and meaningful relationship forever, or whether it was Saturday night, or whether it was simply about freedom to do what I want to do in my own time. So that notion of losing control and getting hooked into something that was ugly and unpleasant and would control your life was something that tested really, really well, and that's what drove the direction on that piece of work. So that's an example of how we would try and do that.
Clive, great talk, thanks. Mike Lee from the Technology Association. In a previous life, I worked in the smoking control on that fuel company, and we believe, mainly because the tobacco industry told us, about 50% of their customers were self-medicating subclinical depression. I suspect it's similar in the alcohol industry. I don't know. It seems like there's a real opportunity to close some dots up here. Are you doing anything looking at more holistically?
Yes.
How these things integrate?
Yeah, very, very, very much so. So we're, aside from the alcohol levy funding and some money that we get around problem gambling, which is levy funded as well, the rest of our work is funded via Vote Health. And one of the challenges in some senses is that we are often quite siloed in our thinking. So we'll have a team that's working on one thing and a team that's working on another. And yet we're well aware that with a population focus, people don't live their lives in compartments. So we are doing some very specific pieces of work that are quite targeted and that we're doing some evaluation over. For example, with pregnant women. So where you're working with pregnant women, particularly Maori pregnant women, around issues involving alcohol, tobacco, depression, and potentially nutrition. But one of the points I didn't make is in some cases we're not always the people that will front that work, because we're not always the best person to actually interface in those circumstances. So there are other relationships that may play in at certain times, for example with particular iwi or particular groups, or through other intermediaries as well, such as, for example, midwives. So we've got a series of relationships, and some of them are geographically bounded, some of them are national, some of them are bounded in other ways. But yeah, and it's a fascinating area because, what the legislation requires us to do is inspire New Zealanders to lead healthier lives. That's a big and broad remit, and it's not a siloed remit because people don't live their lives in health topic isolation.
Yeah, in fact, if I just make another comment, I left the industry before this particular work was finished, but there was a hypothesis that one of the things that was driving the increased use of SSRIs was a reduction in smoking, so taking away the self-medication. But I don't know where that went because I
Yeah, and I think, one of the lessons we've learned from the National Telehealth Service is that people ring the depression helpline who haven't rung the gambling helpline, yet report an issue with gambling. So, that's something they've told us through the integration a year ago of the National Telehealth Service, and the fact they've got the escalation pathways to manage that, I think, is another helpful spin-off of that Sindel contract. The other thing I'd say is that allies come in unlikely places for us. So we do some work around problem gambling. Tell me when you've had enough. But we do some work around problem gambling where we partner the hospitality trade now. Now, if you think about problem gambling, typically you might have historically worked with advocacy groups, and we still continue to do that stuff. But there are operators of Class 4 gaming venues, in other words, pubs and clubs that have pokie machines, who have very tight host responsibility rules and who are policed by the Department of Internal Affairs, yet actually don't want people experiencing gambling harm on their premise, because it's not really, I'm assuming it's bad for business. And anyway, morally, they don't want it. So lots of the work that we've done recently has been about targeting resources that recognise the signs of harmful gambling for use that we've co-designed with bar staff and Class 4 venues. So it's resources they use. Here's a card you can hand out, here's something else you can do. And what we've been able to do is find that we've actually been able to advertise some of the gambling messages either on gaming machines or on cash points that they have inside those venues. Take a break, is your gambling getting much to you? Are you feeling sick to the pit of your stomach? And stuff like that, in language that works for gamblers, for those who are being targeted because we've done the testing, but in venue, because you're trying to, I guess a Sally was saying, you know, when she's talking about sparks, what you're trying to do is engage with the right people in the right way at the right time in a way that works for them. And that's what we devote an awful lot of time and attention to trying to do.
Okay, thanks very much.